chosen? Martin?
Well, you know, all we're really looking to do is to modify this plaque so that a balloon will dilate. The other thing to say is it's very heavily calcified and it's very long. And although with the right technique it's really very unusual nowadays to have slow flow, if this is the very sort of lesion that if one is too aggressive with the burr, then I think it's possible. So I personally would be pretty conservative and go with maybe even a 125 just to, and then try with a balloon.
125.
And if a 125 allows a balloon to inflate, then it's done its job.
Okay. Is it the strategy will be 125 followed by the balloon inflation, or 125 followed by the larger burr size, 1.5?
I think you have to think conceptually, and all you're trying to do is to allow you to work with balloons and stents. So if a 125 burr allows you to do that, and you can test it by leaving the rotor wire down, placing a balloon on the rotor wire. If the balloon inflates, then you're ready to go.
Martin, what is the risk of no reflow with repetitive rotor ablations? Is there a high risk? Is that why you would choose a small burr then balloon rather than stepping up in burr size?
I think the risk is very low. I think, you know, with the right technique, which I always describe as short runs and big pecs. So you just touch the lesion, allow the burr to do its job, withdraw the burr, allow the flush or the blood to flush downstream. And as long as you're not too aggressive, and as long as you don't have in your head that you're really trying to debulk the lesion, because that's not what you're trying to do. I think you're trying to modify the lesion. So the other thing to mention here is I'm gonna sort of step back here, because I think with the rotablator personally that you should limit, when you're using it in your cath lab, the people who work together. It's definitely a two-person procedure with someone controlling the wire as the device is advanced. So I'll just let the team who are used to work together get the burr to where it needs to go. And so obviously what we now do is to just test the spin speed to make sure we get that right. We're currently on Dynaglide. I'll change that to the cutting speed. And for me, I don't know what the team here do, I always spin at about 150.
We used to have a higher speed of rotation. With small burrs, we go to 190,000, and for the larger burrs, we lower a little bit of 10,000. That's how we do. So we're going to test, and during the test, we have to make sure that we don't touch any towel or gas, because it will grab on the burr, and we could get into trouble.
Okay.
Okay, merci. Donc 90 000. So for the insertion of the burr, we have to make sure that the Y connector is very, very widely open, not to damage the burr. At that stage, we look at two things: the distal, the tip of the guiding catheter. It's difficult here because the LED is quite long, but we try to have an eye on the tip of the catheter and the tip of the guide wire also.
But often I think it's the guiding catheter that's the...
What you can do is to, when you cannot see the guiding and the tip of the wire, is to change the field of the, and to go into 25. And certainly should be safer. It's a good trick to teach to the...
So I then gently and...
Yes.
Before seeing the results, can I ask the audience who is performing rotaplators? Who did? Okay, not a big number. So can you demonstrate some of the tips and tricks in rotaplators? I mean, the guiding, using pacemaker or not? Why do you use fine cross here, not using the rota wire directly? Are you going to use two wires with this strategy here to put two wires or one wire? Because
no, that's concerning first of all the wire. We use the rotor wire
and the soft tip rotor wire normally. And in this anatomy, I think, and we discussed this morning with Ibrahim, an experienced operator can place the wire in distality without inserting coaxial balloon or the Terimo device. But you know, to be safe, they prefer to place a BMW wire in the distal LED on the BM, which is more, the torque is much better than the rotor wire. Second, on the BMW wire, they advance the micro catheter and place the micro catheter in the distal LED, remove the rotor wire, the BMW wire, and through the micro catheter they advance the rotor wire and place the distal rotor in the distality. What we have to for the trick, what is important is to be sure that the distal part of the distal tip of the rotor wire is in the LED and not in the small branch, a small septal or a small diagonal branch. We have to be sure that the rotor wire is in the LED. So normally we take two views in order to be sure, and you test to be sure that the rotor wire, because when you are activating the burr, the wire can create a dissection or a perforation if you are in the small branch. So be sure that you are in the main vessel. Then, after placing the rotor wire, the question was the size of the burr. The size of the burr. It's a LED, it's a male LED. The diameter is around 275 to 3 millimeter, particularly in the proximal part of the lesion. So normally we have to follow, to respect the ratio, diameter of the burr, diameter of the vessel, around 0.7. So for a 3 millimeter balloon, we can have, without no problem, we can use a 1.5 millimeter burr. The problem here is, first, there was somebody tell that the lesion is quite tortuous, and this increased the risk of dissection of or slow reflow or perforation sometimes if we take a large burr. Second, the length of the lesion and the length of the material to debulk the plaque burden is quite long. And so, if you use a large burr, you can have the problem first of distal embolisé, no reflow phenomenon. This is the first complication. Second, to have dissection or perforation in the tortuosity. So it's a reason why, for the safety concern, they prefer to start with a 1.25 millimeter burr, which is the lowest size of the burr. Then the question is, after 1.25, what is the strategy? And we have two strategies. Go direct to the balloon, 2.5 millimeter balloon, or choose a larger burr, that is, we move from 1.25 to the 1.5 millimeter burr. Of course, it's more expensive, but this is the strategy. Normally, we use in our center, because of financial constraint, a single burr. We try to use a burr and follow by balloon and the stance.
Are you using guiding 6 French or 7 French?
In this case, I think it was the 7th French guiding catheter, but you can use rotablator with a 1.25 millimeter burr and 1.5 millimeter burr easily with the 6th French guiding catheter.
Are you still using pacemakers, temporary pacemakers?
No.
Okay.
We used pacemaker at the beginning of experience in the years 90s, particularly when we rotablate the big right coronary artery.
If I
Yes.
may,
Do you use also 2B3A prophylactic before starting the rotablator?
No, we don't use 2B3A. What we use in routine is a cocktail with nitroglycerin and verapamil,
Just to prevent no reflow?
the spasm and no reflow, and to have a maximum distal vasodilatation of the vessel. Other comment? Maybe Ibrahim, you can comment, or
I think one of the very important lessons from this case is that, as you said, that if cath lab directors or hospital staff could invest in a rotablation, it's a good investment.
Sure.
It's much more rewarding than having 2-3 IVUS machines and no no rotablator. The other thing is, I mean, in my personal experience, you could probably try to do balloon for this case, and you will never be happy. You might, spend a long time, and at the end of the day, you will not be able to advance a stent because of tortuous calcification. So I think rotablation strategy, I mean, if you can learn one thing from this case, is think of rotablation strategy if you have a very heavily calcified lesion. The other thing is how to get trained. If you're not trained in rotablation, I mean, I think Boston Scientific, who still sells the rotablator, can set you up with a training program for rotablation. So you cannot today purchase a rotablation and try to use it. I mean, you have to be trained in the principles of rotablation. You know, there are certain tips and tricks you need to learn, and then you will be licensed to use the rotablation. So I think this is the thing that I would advise my colleagues here.
Absolutely. There is a learning curve. You need training. You need to learn a technique. But really, when we have learned, it's really easy to handle. Really easy. It's really the burr, the system is doing the job. We have nothing to do, just to advance and push back, and the lesion open slowly.
John, one thing we use in Kuwait, and I don't think a lot of centers use, I mean, I don't think it is very famous, and I'm not advising or making propaganda for this, is laser. And we still use laser, but not in this kind of case, because this is heavily calcified and laser will not do any job. If you had a very, fibrotic lesion that's not opening with a balloon, you expect it's open. If you happen to have a laser, I don't know if you have it, then you could use it. But in this kind of lesion, which is heavily calcified, laser will not work.
Sure. Absolutely.
Final question. Regarding the distal left main, was there any concern about using rotablator with that kind of 40% at least distal left main?
No, it's true there is a plaque, but if you use a very small burr, 1.25, even with the 1.5, you cannot expect any problem. No, really.
Professor.
With rotablator, the risk of dissection proximal to the lesion is exceptional. When we have a problem, is at the side of the critical point of the lesion.
I think one other point in regards to rotablation is I've seen a lot of variability in terms of the burr sizing and the concept of debulking versus plaque modification. I think most of the operators that I've seen when they use the rotablation, nobody is using rotablation as a definitive treatment. It's almost always basically as plaque modification. Now,
absolutely.
The issue is with the burr sizing, with the 1.25 with this vessel, which is 275 or even 3 to my eye, is one risk you have, you may not have full expansion in your stents. I think most of the time if you use 1.25, even 1.5, you will be able to deliver your balloon and stent later on. However, the issue would be, are you able to really expand your stent? Because if you look at the IVUS, if you use a small burr, if you look at the IVUS, you would not have enough crack on that calcium. And when I see this case, I would have used probably 1.5 for sure, and I would have gone up to 1.75. I'll be a little bit more aggressive, especially for the proximal LAD segment.
Yeah.
And that's one point that I may need to just put it up to the
it was a good discussion I remember when we recorded these 5 cases according to the size of the burr. Personally, I was pushing for the 1.5. The other guys in the cat lab, there's 1.25. Okay, for safety reason, we take 1.25. But I'm sure that in this case, 1.5, we do the job perfectly with low risk of complication.
I'm still need some confirmation of the use of ballooning.